This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Injury titled Neuroworsening from a Normal Glasgow Coma Scale Motor Score in the Emergency Department is an early predictor of neurosurgical intervention, hospital outcomes, and longitudinal disability in traumatic brain injury, a TRACK-TBI study.
This is a topic that hits home for anyone who has spent a night on call. We've all seen that patient who arrives in the emergency department looking relatively stable. Specifically, they have a normal Glasgow Coma Scale Motor Score, or GCS-M, of 6. But then they take a turn for the worse while still in the ED.
Exactly. And while we have very rigid protocols for managing neuroworsening once a patient is in the ICU, this study points out that our understanding of neuroworsening in non-ICU settings like the ED is actually quite limited.
It's a critical gap. If a patient is already in the ICU, we're expecting trouble. But when they arrive with a normal GCS-M, there's often a false sense of security. Ilara, let's dive into the core objective of this TRACK-TBI analysis.
The researchers wanted to assess the specific relationships between neuroworsening in the ED and several key factors: clinical radiological injury, blood-based biomarkers, the need for neurosurgical interventions, and longitudinal outcomes. The unique part here is the inclusion criteria. They specifically looked at TBI patients who had no GCS-M impairment upon ED arrival.
So these are patients who are obeying commands when they first see the triage nurse or the trauma team. They are the GCS motor 6s. Now, the study defines neuroworsening as a decline from that normal score. Why is that specific metric so important?
Because the GCS motor score is arguably the most robust component of the GCS for predicting surgical pathology. The study found that when a patient drops from that GCS-M of 6 in the ED, it acts as a powerful early predictor.
And the first thing it predicts, which is of most interest to our audience of residents and attendings, is neurosurgical intervention. If they drop their motor score in the ED, the likelihood that we'll be taking them to the OR for an evacuation or a monitor increases significantly.
Right, but it's not just about the immediate surgery. The paper notes that this early neuroworsening also correlates with clinical radiological injury. Essentially, the drop in the exam is often the clinical manifestation of a worsening radiographic picture. Think expanding hematomas or increasing edema that we're seeing on those initial or repeat CT scans.
I think we should highlight the mention of blood-based biomarkers here. The TRACK-TBI group has been at the forefront of using biomarkers to quantify brain injury. In this study, they looked at how these biomarkers drawn early on relate to that clinical decline. It suggests that the biological hit to the brain is measurable even before the patient clinically crashes.
It really emphasizes that neuroworsening isn't an isolated event. It's a window into the underlying pathophysiology. And what's truly sobering is the longitudinal aspect of this study. This isn't just about what happens in the first 24 or 48 hours.
Right. The study explicitly links ED neuroworsening to hospital outcomes and longitudinal disability. That means a GCS-M drop in the first hour or two of arrival carries prognostic weight for months down the line.
It changes the way we talk to families in the ED. If we see that decline, even if we fix the immediate problem with a burr hole or a craniotomy, the study suggests that these patients are on a trajectory toward higher rates of long-term disability.
For the residents listening, the takeaway here is about vigilance. A normal GCS-M motor score on arrival is a baseline, not a guarantee. The neuroworsening assessment is just as vital in the ED as it is in the ICU. We can't wait for the patient to be in a monitored bed to start looking for these trends.
And it reinforces that we should be integrating the clinical radiological data with the exam. If the biomarkers are high and the imaging is busy, we should be anticipating that neuroworsening.
It's an excellent reminder that the ED is a dynamic environment where the most critical neurosurgical decisions are often made. This TRACK-TBI study provides the evidence we need to treat any GCS-M drop from normal as a major red flag for both surgical need and long-term recovery.
Absolutely. It's about moving from a reactive stance to a proactive one.
Well, that's all the time we have for this episode. Thank you, Dr. Alara, for breaking down this important paper from Injury.
My pleasure. We'll see you next time on the Neurosurgery Hub podcast.